Wait a minute. Wait a minute. You know, this is, excuse me, a damn fine cup of coffee. I'm gonna let you in on a little secret. Every day, once a day, give yourself a present. Don't plan it, don't wait for it, just let it happen. It could be a new shirt at the men's store, a catnap in your office chair, or 2 cups of good, hot, black coffee. Like this. A present. Like Christmas. Oh, man, that is the spot. Nothing like a great cup of black coffee.
Samsung monitor over there on the right that we'll be able to see too, that they can see. So it seems pretty chill. I guess we hopefully won't have to use the bell. And we have 5 extra minutes in this session. We run until 12:45, but we're only scheduled till 12:40, so we have a little bit of time to work with.
That's good. People tend to go over.
Yes, indeed. Shall we? Yes, let's. Hi guys, we're going to get started in just a second if folks can find their seats. Great. Hi, welcome to session U, strategies to enhance Hep C testing and treatment. Shashi Kapadia from Weill Cornell.
And I'll be the other co-chair, Mia Biondi from York University, Toronto, Canada.
All right. We've got some exciting presentations lined up today, so let's just start off. First, we're going to introduce Mr. Christian Marcoux. Christian has over 20 years of experience working in the specialty drug industry, has launched dozens of national patient support programs, and over the last 5 years has developed a patient management software platform, launched a national support services company, and established specialty pharmacy and wholesale business. And he'll be talking to us today about HepCure HCV model of care.
Well, good morning, everyone. Before we begin, I'd just like to take a quick moment to thank INHSU for the opportunity to be here today, not just for myself, but for my team, and for allowing us to share our successes and the learnings from a lot of work that our team has done and our efforts to screen individuals and to improve linkage to care during a global pandemic. In terms of some housekeeping items we'll get through really quickly, we'd like to thank and acknowledge the corporate sponsorship that we've received from AbbVie Canada, which was used in the development of our HCV elimination model of care. Without this support, we would not be able to be where we are today in terms of the evolution of our model, and so we're very thankful for the support that has been provided. We'd also like to acknowledge Hugh No from Touro University, who supported us in both preparing our abstract submission as well as our INHSU presentation. And last but not least, we would like to also thank and acknowledge the thousands and thousands of individuals who participated in our programming from various marginalized care settings, and many of whom use drugs on a regular basis that participated in our research as well. Our mission. So HepCure's mission is to provide harm reduction education, but also to work with community-based agencies and partners. Hundreds of partnerships have been established through this model of care in the last few years to be able to advance and fast-track both screening but linkage to care for underserviced communities, many of whom live with and or have had prior risk factors for Hep C infection, and to do so in a safe and an effective manner and also in a non-judgmental manner to ensure that we can achieve positive treatment outcomes for clients. We accomplish this through the use of proprietary technology, customized workflows, and through a shared passion through our people, which is probably our most important asset, to ensure that we can make the difference in the lives of those who are less fortunate and those who are most at risk of Hep C infection. We've also accomplished our model of care through not just one specific item, but through several channels. And some of those channels include a multidisciplinary team, having clinicians such as physicians, nurses, patient advocates, outreach workers, pharmacists, all integrated into our model of care to be able to provide better care to very often a very transient patient population. And also by bringing testing, both point of care testing as well as phlebotomy services directly to where marginalized individuals and those who are at the highest risk are most comfortable accessing services. So whether that's drop-in programs, drug injection sites, respites, hotel programs, bringing the care and the services directly to where they actually reside or where they frequent services on a regular basis. We've also accomplished our model of care and the successes of our model of care and the learnings which we're going to share with you today by providing patient-centered care, by facilitating free and free transportation to and from medical appointments that are needed to be able to either diagnose clients or to be able to support them throughout their treatment, and also by offering weekly delivery services of medication so that we can monitor patient compliance much more closely to ensure optimal outcomes as well. One of the items that has had a lot of success in our programming has also been the implementation of program incentives. And so many people have different viewpoints on program incentives, but what we're asking from our participants is we're asking for their time. We're asking for their engagement. We're asking them to seek a diagnosis which will determine whether or not they actually do require treatment or whether or not they've actually been cured or if they've self-cured, to ensure that they can make better informed decisions about minimizing risk factors in the future. And so as a result, we've implemented several incentivizations throughout our programming, from meal vouchers in terms of being able to have gift cards for food, to providing our clients cell phones for 4 to 5 months at a time while they're on treatment, to be able to reach out to them on a weekly basis, coordinate deliveries of medication, monitor adherence to medication at the same time, but also not just during treatment, but post-follow-up care to make sure that the clients are also accessing blood work and phlebotomy services to ensure that they know that they've been successfully treated or they know that they've actually been cured as well. And also the implementation of cash incentives for participation and for meeting certain milestones within our programming as well. This has also allowed us to provide better adherence support, especially as a result of the cell phones, by either through SMS or through scheduling weekly appointments, by providing adherence reminders or providing clinical interventions on a regular basis to improve that adherence as well. And last but not least, also through other harm reduction initiatives and education. You'd be surprised how many clients out there have no idea what the transmission factors for Hep C are. They don't know that they can get it from sharing a pipe. And so when we sit down and actually explain to clients what those risk factors are, for the first time for many of them, it's an aha moment. They had no idea. And so a lot of the clients that we've seen have been infected because of the lack of education. And when they are positive, it's understanding what does it mean to be antibody positive, right? Many of our clients that we ask that question to, we also have to appreciate they don't often have a college or university degree. And they don't want to feel stupid either. And so as a result, many say that they do understand because of the fear that they're going to be discriminated or looked down on when they don't understand. And so explaining things in a way that they can understand that's meaningful for them allows them to have a better understanding of where they're at with their diagnosis, what they can do about it, and how they can prevent themselves from being infected and those that they love as well from being infected as well. And also by providing very comprehensive follow-up care for our clients throughout the cascade of treatment and also up to the point of diagnosis, to be able to bring all of these services together to make an impactful difference in the communities that we service. It's important to keep in mind that our organization was founded a few months before the global pandemic. And so whereas many providers closed their doors for many reasons, shortage of staff, shortage of PPE, fear of this global pandemic, we decided to continue working throughout the pandemic. And so that came with its own obstacles and challenges. But as a result of working through the pandemic, where most providers ceased providing services, it also allowed us to perfect and to improve our programming, whereas we weren't dealing with the same types of competitive pressures with various providers providing duplicate services or overlapping services. It really gave us a unique opportunity to be able to customize the journey and the flow for our clients. And so our model of care was established on 3 main pillars. We call this our trifecta. Directly through outreach, we know that if we want to eliminate Hep C, we have to get to the communities and service the patients where they're most comfortable receiving care. Through the use of geomapping technology to identify more than 500 social support programs accessed by the community, and partnering with more than 30 pharmacies to provide localized care. And through the use of our patient registry, which tracks consent, treatment journey, and workup for clients throughout the cascade of care. As a result of these pillars and as a result of our collective efforts, we were successful between February 2021 and January of 2022 in screening and linking more than 3,300 clients through our programming. And 40% of all of our program participants, so more than 1 in 3 clients, was exposed to prior Hep C infection, of which we were successful in diagnosing 91% of all program participants, and more than 50% were deemed to be viremic. We were also successful in linking 80% of those same clients to care, of which 92% chose, because of the personalization of care and services, to receive services through our treatment program. And what we saw as a result was over an 85% medication compliance to the end of treatment in a patient population that otherwise typically has very, very lower treatment outcomes as a result. Again, all based on these 3 factors. But what I don't want to do today is leave you with the fact that we've invested substantially in technology, we've leveraged geomapping, and we've leveraged outreach, because not every organization has access or the knowledge or the skills or the staffing to be able to deliver effectively these 3 pillars. What I would more like to leave you with today is our collective learnings. When we talk about consent, consent is not just saying, hey, come for a point of care test, it's going to take 5 minutes, that's the end of the process. Consent is explaining what it means if you're going to be positive, what the next steps are going to be, if they're ready to go through those next steps as well. And so that's a difference between saying this could take 10 minutes and this could take an hour. Do you have an hour? Are you willing to commit an hour? And if you're not spending our time with folks that may not be as interested, may not be ready to know their diagnosis, simply because they're participating for an incentive. Yes, an incentive gets them through the door, but what keeps them is understanding, are they ready to have that conversation and to seek access to services? We've modified our point of care handling process, where we used to register clients and then do point of care. Now we do a verbal consent before any registration. As long as they consent and they understand the expectations, we do a verbal consent to expedite that time. If we're going to take 5 minutes to register them, and that's 5 minutes we could have already been waiting for the result for the point of care test, we're minimizing the amount of time that they have to wait with us in our care to receive those results. We've also modified our intake protocols, where we now decide which clients will be allowed to participate. We know there's a direct relation between many clients who have no address at all, they're living in the parks, they're living on the streets, they have no phone, and many of those clients are not ready for care. It's not just about registering clients, it's about registering clients that are in a better position, and although they're in marginalized care settings, are ready to access treatment or ready to access services at the same time. Okay? In addition to that, we've also leveraged online apps through laboratories that allow for self-check-in. So where some labs may take 30 minutes or 45 minutes, we're registering them at the point of care confirmation. That way we can reduce, by the time we go through the education, the counseling, a clinical consultation, we're reducing 20, 30 minutes of their wait time. And now we're not saying, by the way, if we don't have a phlebotomist on site, we're going to take you to the lab, but that's going to take another hour now. We're minimizing the time. And so it's very important when you're dealing with marginalized communities and those who use drugs to understand that time is of the essence, and that minimizing the amount of time that they waste, that they spend in their participation, is crucial to get them to that diagnosis. We've also implemented mandatory contact information so that we can follow up with them. And whether that's an address of a shelter they're living at, whether that's an email, whether that's a mode of communication they check regularly so we can stay in contact with them, or if they have no contact information, providing them a toll-free number that they can call and they can access our care and services 24 hours a day, 7 days a week, 365 days a year. It allows them to seek follow-up, to know what their status is at any time that's convenient for them, and for us to keep them on therapy as well. We've also implemented discharge processes for clients when they're not compliant with our processes, so we're not wasting unnecessary manpower and effort. If they're proving to be disengaged at this point, after making the commitment, we can refocus our efforts and our time on those who are more interested in access to treatment if required. We've also replaced our incentivizations for positive patients who complete our full workup process with cash rewards, and we've seen a direct correlation and increase in the participation and the engagement for doing so. As it relates to treatment, we've also limited the quantity of medication to a week's supply at a time, to providing weekly deliveries of medication, and also to using the cell phones and setting alarms on those cell phones as a daily reminder to take their medication as well. As a result, when we look at the last 8 months, so we looked at a year of data. Now we're looking at the last 8 months, which is from February until September of this year. We've screened just as many patients. We've screened over 3,600 patients as compared to 3,300 over the previous 12 months. The big difference, though, is we're recruiting more qualified candidates, and we're not seeing a shortage. Really, we have the opportunity to increase our count to close to 5,000 clients this year, which is about a 33% increase. So we're not seeing that Hep C is going down. We're seeing that we're reaching more of the right qualified people and that we're having better success. And as a result of putting these criteria in place and making these programmatic changes, what we're finding is that we're still seeing the same level of antibody results or previous exposure. But what we've done is we've reduced the diagnosis rate, or we've increased our diagnosis rate by 6% and dropped our non-engagement rate by 6%, while still maintaining the same percentage overall of viremic patients, patients that are linked to care, patients that are treated, and also the outcomes of treatment as well. So in conclusion, our success, we've been successful with our programming and diagnosing almost 100% of all program participants and linking 80% of clients to care. We've implemented new work processes and over 800 programmatic changes to further improve our patient retention, and we are currently replicating our program in British Columbia to demonstrate the feasibility of a countrywide elimination model. In closing, I have 15 seconds. I would just like to thank our team, both past and present, who have contributed countless hours. I cannot count the amount of hours that they have contributed, but having extraordinary people means providing extraordinary care. In conclusion, thank you.
Thank you so much, Christian, for such a fantastic presentation. Unfortunately, we don't have time for questions at this point.
It's perfectly fine.
So we will move on to our next speaker. So we'd like to welcome Dr. Benjamin Eckhart. Dr. Eckhart is an infectious disease clinician and researcher at NYU School of Medicine and Bellevue Hospital in New York City. Dr. Eckhart's research focuses on evaluating models of care to facilitate access, engagement, and retention of active injection drug users and drug use in infectious disease treatment settings and care settings. And I'll let you introduce your talk.
Great. Thank you all for being here. I know you're all here for the Combi van, but you're going to have to put up with me for 15 minutes, and then we'll get to the Combi van. So as you can see, this was definitely a team effort. Many of you are here today, and I want to thank you personally. No conflict. So accessible care really is a concept that our team has been working with for over a decade, and it actually predates all of us, and it's work really with Brian Edlin and the late Michael Carden. But it's really low threshold care provided in programs designed specifically for people who inject drugs in community-based locations where they can comfortably access care without fear of shame and stigma. And in this particular study, it's co-locating care within a syringe service program. Some of the early work actually occurred with interferon, but I got onto the study in 2014 with the FDA approval of sofosbuvir. And we started at that time, as it was approved, pretty much treating people who inject drugs for their hepatitis C, co-located in the Washington Heights Corner Project, which is one of the syringe exchange programs. Between 2014 and 2016, we did a pilot study of adults who were actively injecting and were RNA positive. We recruited 53 individuals in that study with the primary endpoint of testing cure at 12 months. And what we found was that high rates of cure were achievable in this patient population. So we achieved 91% observed SVR in that particular population. However, there were kind of multiple, modes of engaging people in care at that time, and we weren't really sure how effective this is in relation to other interventions. So we expanded on this study, and the primary results I'm going to present here, but the accessible care randomized controlled trial, which was conducted between July 2017 and recruitment through March 2020, which is when we stopped early because of COVID, with a year follow-up to March 2021, recruited a similar patient population. So adults that were actively injecting that had a detectable RNA or confirmed positive were randomized to either accessible care, which was on-site everything, so medication medical evaluation, phlebotomy, treatment follow-up, versus usual care. And usual care in New York is actually pretty robust, even at that time. It was on-site care coordination, it was on-site peer navigation, but it was off-site care. And this is through the New York City Department of Health Check Hep C program. The primary endpoint of this study was similar to the other, which was achieving SVR12 within 12 months, with secondary endpoints looking along the HCV treatment continuum. Again, just taking one step back, again, usual care was not just, we're gonna see what happens to you. Usual care was enrollment, same-day referral to our on-site patient navigation team, which consisted of a care coordinator and a peer. These programs are located throughout the city, embedded within multiple syringe service programs in New York City, and then additionally within many of the safety net hospitals and clinics around the city. So it's a pretty robust program that has been published here in this clinical infectious disease article back in 2017. In terms of our study, we assessed 572 individuals for enrollment and ended up randomly assigning 167, about equally between the accessible care arm and usual care. In the accessible care arm, we did exclude 2 patients post-randomization. One, we did have an exclusion criteria for those with advanced liver disease, thinking they were better cared for in a hepatology clinic where additional services could be provided, and one was actually incorrectly enrolled. The final sort of numbers were 82 and 83 in each arm. In terms of demographics, you can see here the mean age was equal between the 2 arms, about low 40s, predominantly men, a large percentage Hispanic, as is sort of expected in New York. I think a couple of things that were striking, we did enroll individuals that were predominantly homeless, or at least reported homelessness in the past 3 months. And different than the United States, I know many of our European and Australian colleagues might find this not a problem, but in the United States, we were enrolling a lot of people that did have insurance, which was great, although it was not an inclusion criteria. And we recruited across all 5 boroughs of the city. It was not just Manhattan residents. We'll get to that in a second. Interestingly, we weren't only recruiting participants from our needle exchange. So the Lower East Side Harm Reduction Center, abbreviated their LESHRC, was only a site for about a quarter of our participants. We began seeing patients come from other syringe service programs because they heard about our program, because peers at those sites started hearing about our programs. Peers were referring individuals, and we were getting other referrals. So you can see the recruitment really came from all different settings. Additionally, a large percentage of these individuals reported daily injection drug use over the last 30 days, and you can see some of the other information there, about 7% HIV positive in addition. So in terms of our primary outcome, in the intention to treat analysis, we were able to achieve SVR12 in 55 of the 82 individuals in the accessible care arm, or about 67%. Again, that's not SVR rate. So SVR rate, I guess, of those initiating therapy is on the following line, which is 55 out of 64, or 86%. And the usual care arm, which again, care coordination, peer navigation, off-site treatment, they were able to cure 19 out of the 83. And similar rates of SVR12 for those that actually initiated therapy, with similar rates of loss to follow-up. When we look at the care cascade, I think, the most dramatic drop-off really is the engagement with an HCV provider. And so a lot of the attrition in the usual care arm was linking those individuals with care providers. What we found was, sort of in qualitative interviews, is that there wasn't a whole ton of interest in seeking care in the community just because of concern about stigma and experience with a lot of these institutions in the past. And that obviously was overcome in our sort of embedded care model. When we look at the subgroup analysis, really the accessible care intervention across the board was favored. So overall, you can see the relative risk of 2.9, but independent of age cohort, gender, race, ethnicity, homelessness, all of these individuals seem to do better Interestingly enough, a lot of people from distance boroughs actually seem to do quite well. Similarly, across the board, independent of what needle exchange you came from, people were doing better with accessible care. The other thing, I think what we were interested in particular, and again, it wasn't a study that was powered to detect this, was those that were daily injectors, thinking that they were probably going to be less likely to seek care in the community. And I think there's a trend towards that. So the daily injectors, there's sort of a trend that there might be more favorability with the accessible care model compared to the usual care model, which I don't think was surprising to us. Of note, we did follow people for reinfection. So we had 4 participants that were reinfected over 57.9 patient years of follow-up. So our reinfection rate was 6.9 per 100 patient years. I will note that we did, as part of our treatment, and we don't really talk about it in this presentation, but we had an on-treatment reinfection prevention sort of training. It lasted a half an hour to an hour, usually tried to do it while the individual is on treatment to try and understand their individual behaviors which might put them at increased risk for reinfection and how to avoid such risk behavior. One sort of area that I like to highlight, again, going back to our consort diagram, is those that were excluded prior to randomization, and specifically those that had pending RNA. And I think this remains one of the biggest barriers to treating this patient population, which is getting them a confirmatory test. So 167 individuals were not enrolled in our study simply because they did not have an RNA test. And I think this is a growing issue as we start following these people that have been treated, have been cured, but still might be at risk for reinfection. Figuring out ways to get them RNA testing or some surrogate is increasingly important. So in conclusion, co-located HCV treatment or low threshold treatment within a service program provided superior cure rates compared to co-located care coordination and community-based treatment. The success of the program appears less about increasing physical accessibility through co-location and more about providing a low threshold, non-stigmatizing community environment where participants felt respected and comfortable. And we sort of drew that conclusion based on the fact that participants were, again, coming, at least 2/3 of them from outside syringe service programs or not engaged in the syringe service program in general, but knowing that that site was not going to stigmatize against them, or hearing that that program was not going to stigmatize against them. And as I mentioned before, 167 screened individuals were excluded from enrollment because they were unable to get HCV RNA testing, and obviously the need for point of care confirmatory testing will be increasingly important. And I will stop there and open up the floor for questions.
Thank you for the wonderful presentation. Maybe as people head to the microphone, if I could ask one to start, maybe possibly go back to your cascade slide, and just had 2 questions. Congratulations on the work. It's obviously very powerful in terms of the 2 different arms. But in your arm where you did do the intervention, what do you think was the reason that there was that small drop between just that intake and baseline lab work completion? As well as, have you looked at that piece between treatment initiation and SVR12 confirmed treatment completion?
Repeat the second part. I think I missed the second part.
Sorry. I'll start with the first one again. Just that initial visit with the HCV clinician to completing the laboratory, and just curious if that's because people had to go out to do their testing and workup, or...
Yeah. So I think, again, I think you're drawing there is a very slight drop in the accessible care. I think it went from 72 to 71, if I remember my numbers correctly. And it simply has to do with, correct me, I may be incorrect, but at that point we were still requiring genotypes. Our insurance companies were still requiring genotypes. And the lab that was drawn ended up having a genotype indeterminate. And the insurance company required us to repeat that lab test, and the patient never returned for repeat lab testing. I lost my slide. So your second question was about the drop-off between...
Well, just if you have the information around treatment completion. You have treatment initiation and...
Oh yeah, we don't have treatment completion. Yeah, so we did not measure adherence. we did not measure, have clearly defined treatment completion. We do know, and I don't have the numbers off the top of my head, how many picked up all of their medication. And there were only a handful that did not, but we did not measure adherence in this study.
Okay, thanks. Take microphone 3, Jason.
Hey, Ben. Jason Grebley from Kirby Institute. Really nice presentation. I think what's really important with what you presented in your study is just, I know we've seen it in the interferon era, but that importance of the on-site sort of wraparound care. And I'm just sort of curious, and beyond the point of care RNA testing component, which it's so clear, I see what you're saying around both things, but have you guys thought, what's the what next in terms of the intervention that you think could be layered on top of that on-site sort of model to further boost things up, I guess? What do you think might be an intervention, or have you started to do some stuff around that?
Yeah, I mean, so one of my biggest complaints about the research community is this sort of vertical focus, right? We're focused in this particular study, and I'm the first to admit it, on hepatitis C as a sole endpoint. And obviously these individuals have a lot of other health, social issues that need to be addressed. So I think the most important thing is to expand on this model in a more integrative care capacity. So what does that involve? Potentially things like HIV prevention and treatment, things like wound care, things like just primary care at low threshold clinics. And I think, you know, one of the downsides of a model that really just focuses on hepatitis C is it's not cost effective, or it's very costly. When you have a clinician on site that's just doing hepatitis C treatment, it's not sustainable. But if you sort of provide more integrated care, not only is it better for the patient, but it's better in terms of sustainability for the institution as well. So I think, you know, it's not a clean research endpoint. And unfortunately, our funders want clean research endpoints for us to power our studies for. But really what's needed is more comprehensive care for this patient population.
I think you raise a really important point, and for all of us doing research in this area to be thinking about what are the endpoints we should be building into our studies to be able to capture some of this stuff and be building into our programs. So anyways, fantastic work, great presentation.
Thank you.
Microphone 4.
I like clean. Olav Dahlgren from us. So I actually like clean endpoints. And, I think when we do these randomized controlled trials on hepatitis C treatment, we should maybe consider to have the main outcome is treatment completion. Because we know now that the SPR rate, if you complete treatment, is very high, 95% or higher. And it's not practical to do the follow-up 12 weeks post-treatment. So I think we should maybe in future trials say that it's treatment completion is the main outcome.
Yep.
So,
Thank you again, Dr. Eckhart.
Thank you.
All right, so our next presenter is Mrs. Mim O'Flynn, who many of us know. Ms. Mim O'Flynn is a registered nurse with a long history of working with patients living with HIV and hepatitis, and she's currently focusing her time on HIV point-of-care testing, screening and linking marginalized and incarcerated patients to hepatitis C care with the Combi Clinic, which she'll talk about with us today.
Thank you so much. Thank you for accepting our late breaker. This is a look at Woodford Correctional Centre, which is the largest correctional centre in Queensland. It's about a 45-minute trip from Brisbane. And before I start, I just need to give a shout out to an amazing doctor who is 16,500 kilometres away, sitting in front of his laptop with a gin, because he just sent me a photo. So that's Dr. Joss. I begin today by acknowledging the traditional owners of the land where I live, and that's the Turrbal and Jagera peoples, and we pay respect to elders past, present and emerging. But I want to also acknowledge the individual and collective experiences of those living with or affected by Hep C, and all the men who were very courageous and willing to be involved in our testing blitz at Woodford. So Hep C elimination in prison, there are a few barriers. You all know this sort of information. It's the testing and treatment requiring multiple visits. In the past, frequent loss to follow-up, venous access for phlebotomy, and people movement. Woodford is a maximum security prison, so the average stay is a little bit longer than our remand prisons, but people get moved from, we've got, I think, 7 prisons in a close proximity in the Brisbane metropolitan area. And of course, the non-barriers are all these amazing men who are willing to be tested. So we wanted to eliminate the barriers as well as the virus. So how did we go about doing this? The game changer is the GenX machine. It has just revolutionised the way that we in Combi work. We have collaborative partnerships with Hepatitis Queensland, Quinn, and Queensland Health. We've got a skilled team. We take the same team into the prisons each time. So we have 2 people only who look after the machines, and that's running 6 GenX, although at this prison we only ran 4. We have the same people who are using the mini vets, so skilled operators as far as collecting. As much as we can all do it, we try and keep the same group. And of course, it's optional to have a 1975 Lucy. So how do we go about it? It's planning, planning, planning. The first thing you need to do, or we did, was find a champion within the correctional centre. And from there, everything is smooth sailing. You get those buy-in from the stakeholders. What we do before we go is we get Hepatitis Queensland team who are very skilled. They go in and educate the officers. We have lots of posters put up. I think we produced about 30 posters for this particular correctional centre. And the GM was very forward-thinking and allowed some of the prisoners to actually sort of peer lead the information. So they went around with some of the posters to try and generate some interest from the inmates. Team training in collection, that's imperative. I worked out a roster for every day, so I knew that I had the right number of people to achieve what we wanted to do. And of course, there's flights, accommodation, equipment, all of that. And that's the back of my car. And I've since learned that I can get 6 GenX in if I'm very careful. My husband packs it for me though. So what were the results of this actual blitz? We worked 9 days, and as I said, we had 4 GenX, so that's 16 tests an hour. We tested 62% of the prison population. It was in March this year. It was during a COVID, we were sort of in between 2 COVID outbreaks, so we didn't actually get to test as many as we would have liked. And what happens, I find, in the prisons is the first few days, because it's an opt-in, so we find that people sort of stand back and then their mates go back to their cell blocks and say, hey, it's really cool what they're doing. And so then in the last couple of days, we've got all these people come flying in, and we just ran out of time, unfortunately. The quarter of the people that we tested identified as Aboriginal and Torres Strait Islander, and about 2/3 had a history of injecting drug use. So we found 27% positive on this particular blitz. 47%, this is really, it's part of my take-home message. 47% had previously been treated. So, you know, we're always happy to retreat and retreat and retreat, but there's a really strong message there as to why we're needing to do that. And proud to say that 98% of all RNA positive scripts were, of all people who were positive, were scripted within 4 weeks. So thanks to Dr. Raj and Dr. Joss. Dr. Joss went back repeatedly. He's amazing at writing up the charts, medication So he's very, very adept at it now, much faster. So this is going to be a little 1-minute video. It's just an elevator pitch of what we actually did. So what did we learn? Lots of things. The local pub is really not very good for food when you've got to go there 8 weeks, 8 nights. But it's really, don't let barriers in prisons sort of be a deterrent for you. Always have an alternative plan. If the officers say, sorry, we've got a lockdown today, what we did in some instances, I always have a little trolley ready, so we actually go out to the units rather than having the men come to us. And that stakeholder support is really very critical, having that champion coming within the prison and supporting us. So what's next? So for us, we really want to know that OST, as we call it, or OAT, is available for all incarcerated people who choose to engage in the program. You know, most of our prisons in Queensland, there's a cut-off of 30. This is a prison that had 1,400 people at capacity. So, and, you know, we'd like to dream big, and it doesn't need to be a fleet of combi vans. You don't have to have silly shirt or anything. It's just, if you go into a prison and blitz, get that pool of Hep C, and then maybe have a Gen X on reception. But you've got to find, you know, that, or clear that body of Hep C. So before I give you my take-home message, it would be remiss of me to not thank Jason and being part of the Hep C Point of Care National Program. It's just changed what we do, how we do it. David and Corey, I have to give a shout out to you because you're always there at the end of the line, and trust me, I made many calls. So we need to do a blitz in every correctional centre is our belief, but the biggest take-home message is that before they put me in a box, we have to have needle and syringe program inside every correctional centre. I work at it every day. We're meeting, Joss and I are meeting Member of Parliament next week, again, to push this message because it just seems extraordinary. You know, it's 2022. And I hear from the officers, you know, they say, oh, you can't have clean needles because they'll use it as a weapon. And I think, well, if I'm going to get jabbed, I'd rather have a clean needle. It's just such a ridiculous comment. So partnerships, as I mentioned, Queensland Corrections, Quinn, Hepatitis Queensland, couldn't do it without all of these people, Kirby Institute and Flinders, and the amazing A-team that I just couldn't work without. Thank you.
All right, thank you so much for a great talk. We do have a few minutes for questions, and it looks like we've got one at the ready at microphone 4.
Hi. My name's Ian. I'm an outreach worker on the Hep C team in Portland, Oregon.
And I'm curious to know if you have any advice on making those relationships with the stakeholders in the prisons. It's been a big barrier for us in getting into testing in prisons. It's just communication is really challenging or non-existent. And so any advice you have on building those relationships at the prisons?
Sure. What we did was start with a low security prison. So Paling Creek is like a big farm, and we were just very fortunate that the GM was very inclusive of what we were doing. He let us drive Lucy right inside the prison. So it was just extraordinary the way he got all the officers to engage. It's a large, many acres. I got a tour of 1 hour over the whole, because it's up on a hill. So we were lucky that from the very get-go, he published in the QCS media, so then all the GMs in Queensland knew about the combi blitzes, and from that we were able to leverage where we next went. So we're very, very lucky. But when I go to Townsville or Cairns, I'd always take a flight up there and make time to meet with the nursing staff, all the correctional officers, have a day, walk around, take Sticky Barn. It's amazing what you can do with Sticky Barn. So I had a champion at each correctional centre, but it was like, ripples.
Thank you.
Hi, Sophie.
From the BC Centre for Disease Control in Canada. So I just really want to echo your call for OAT or OST to be available in all of the correctional centres everywhere, plus NSP, plus why stop there? We need overdose prevention sites or supervised consumption sites in prisons, because NSP does not prevent overdose. So
Yeah.
I think Queensland's a great example of how you can un-eliminate hepatitis C in a prison. Lotus Glen, first prison to demonstrate elimination, first prison to un-eliminate hepatitis C. So we really need harm reduction, and I just really want to echo what you're saying there. But I also have a question about the testing. So you mentioned that it was opt-in, and you had 66% or so people tested. But it sounds like that wasn't because of people buying into it. It was more an access or an administrative issue. Can you elaborate? Was it just you didn't have enough time to test everyone in that prison?
We ran out of time.
Yeah, so it's not that it was opt-in. Like, I just think we all get obsessed with making things opt-out.
Yeah.
But actually, like, just make the access really
Yeah.
easy.
Poor
and it won't
choice of
matter.
words.
Yeah.
Sorry. Yeah.
Right? If you're offering something people want,
Yeah.
then
It's like Barallan, which we did a couple of months ago, which had a 40% prevalence. We're actually going back there in a couple of weeks because we're only able to do 50% of the correctional centre. So we're going back, make sure we capture everyone.
All right, thank you.
Thanks.
Thank you so much.
I would now like to invite Megan Hughes. Megan is a clinical nurse consultant at the statewide Sexual Health Service of Tasmania, who has been delivering outreach community-based hepatitis C care in NSP, AOD, and mental health settings since 2020. Welcome.
Thank you. I'm Megan. I'm a clinical nurse consultant on the Tasmanian Eliminate Hepatitis C Australian Outreach Project. This is an EC Australia funded project, and we are in partnership with the Burnett Institute, and I'd like to give a shout out to Josh and Jackie Richmond from the Burnett for all their support throughout this project. So here are my disclosures. So a little bit about the beautiful island of Tasmania. We are off the south coast of Australia, and our population is about 500,000 people. We have a really good progress towards elimination of hepatitis C, with 60% of people living with chronic hepatitis C have been treated. Prior to 2020 and the start of this project, hepatitis C care was primarily tertiary based, and then mid-2020 we started up our project. So it's a statewide project, and as you can see here, I get around the state and do clinics all over the place. So what is the TechHal project? Our aim is to provide community-based, flexible, person-centred care and increase testing and treatment for people who are living with or could be at risk of hepatitis C. To do this, we've engaged with priority populations, which we see as, firstly, the needle syringe program, mental health services, and drug and alcohol services. So the project is a nurse-led model of care, and the clinician is me. We have a team of one person doing these clinics. And so what we've created over the last 2 years is a nurse-led service. So in the NSP services, I run drop-in clinics in 6 NSPs across the state. So this has been a really successful part of the project. It's a very relaxed and flexible clinic, and I couldn't do it without the NSP staff who really promote and engage people coming in, that it is a safe space to come in for testing. But it's not just about testing, it's about education and conversations around harm reduction as well. So at these clinics, we do venipuncture for reflex testing. So I take all the blood needed to start people on treatment. So if they come in that clinic and we get all the blood and they are Hep C RNA positive, I can follow up with a phone call to commence treatment. I've just started running drop-in clinics in the drug and alcohol, so the OAT provider services in the state as well. And also I take referrals from mental health services and work really closely with mental health caseworkers and AOD caseworkers to assist people through treatment. A huge part of my job is, as well as treatment workup, to provide intensive case management for people while they're on treatment. And that really varies person to person, what they may need to help support them through treatment. We also provide access to getting co-payments funded, so there's no cost for the client. And we're very flexible about the support we provide. And I liaise with specialist services for those at risk of advanced liver disease. So it's a multidisciplinary approach, and I partner with health specialists, peers, NSP workers. So I'm one person, but they can promote my clinics and promote the service when I'm not there. So we get the message out. We also have incentives on offer to support engagement in the NSP sector. So over the last 2 years, I've tested 346 people in the NSP setting, and we've had an RNA positivity rate of 9%, and really happily 93% of those clients have commenced treatment. In mental health services and AOD services, we have supported them to implement routine screening on admission to service, and then annually after that. So I don't have exact numbers on how many people they've tested, because the pathway is I get the referral for treatment start, and that's where I come in. And I'm really proud that we've got 100% of people referred in mental health services to commence treatment. So I think that's great. Overall, 92% of people referred to the project for treatment have commenced treatment. So here's a little quick look at the characteristics of people who have come in for, who have been hepatitis C RNA positive. Really importantly, I think 25% of people have been prescribed antipsychotics. I really am worried that in Australia, in our elimination effort, we are leaving people with mental illness behind, and we need to have services that people feel that they can come in and we can support people through treatment. Also, 41% of people have come in through the NSP service. So in reflections, really quickly, we need to be flexible, we need to be in the community, and I really thank all the clients for trusting me with their care.
Thank you very much.
Thank you so much. So our last presentation is from Dr. Philip Reed. Dr. Philip Reed is director of the Kirkton Road Centre, a walk-in targeted primary health care service in inner Sydney, which targets services towards marginalized populations. And he will tell us about the preliminary results from the evaluation of HEP at home.
Yeah, thanks very much for inviting me. This is a study, well, it's not really a study, it's an evaluation of an expansion to our testing and treatment program, and it's a sort of preliminary outcomes at the stage. We called it HEP at home because it was about getting Hep C testing and treatment in people's home locations. And I just want to acknowledge the team that did this, predominantly clinical nurse consultants and some health education officers as well. I've also got a couple of disclosures and also to thank Gilead for supporting some of the funding related to this study, to recognise that some of the testing was done through a New South Wales dry blood spot testing programme, and also to acknowledge both traditional custodians of the land that we worked on and also people with lived experience of hepatitis and drug use. So I guess we're doing a lot of testing and treatment in NSPs, homeless hostels, out of buses, mental health services, street-based work. And then suddenly during COVID, we were asked to set up pop-up vaccine clinics by our health department in social housing estates. And suddenly we were going door to door in these social housing estates, knocking on the door and saying, you know, do you want a COVID vaccine? And so we also started to offer NSP in those activities as well and developed a network of local NSP clients. And I guess the point of this was to try and leverage those two things. So the relationship we then developed in the community in those social housing estates, the NSP connectors, and try to deliver testing and treatment at the doorstep of these individuals. So we did incentivize it. We found that that was useful to start. It was very local, so we picked a couple of social housing estates that we knew some of our NSP clients lived in and asked them to kind of almost like snowball recruit people that they knew who used drugs in that area. It was very much led by our health educators and these peer navigators, although the clinical assessments were obviously done by experienced nurses. So thus far we tested 73 people. And although they were offered different types of testing, in reality, it turned out that everybody chose a dry blood spot for RNA, which is what our New South Wales pilot uses. 8 of those people were positive. Sadly, 2 of them who'd never tested before out of that 8 had hepatocellular carcinoma, and we weren't able to treat them through our program. They were referred elsewhere. And then I guess we started the 6 people on treatment and delivered the meds to their home. The bloods were done in the home. The FibroScan was done in a bus that we parked outside the home. Like everybody, you know, going in people's homes, that stopped and started 3 times during lockdowns and restrictions on what we could do. So unfortunately, the continuity of the program has been a bit of a struggle. But we're back on track now, or at least we were until we then had to open a monkeypox vaccination clinic instead. Okay. In terms of the evaluation, about 40% of the people that we test out of those 73 had had a Hep C test in the last 2 years, and about 15 to 20% had never had a Hep C test before. Reasons that they felt that had happened and why it was important to have been offering it at the doorstep were difficulty getting to places, you know, trouble with appointments, other priorities, childcare issues, cost of travel, that kind of stuff. And we also asked people what they thought about the program, and obviously they engaged with it, so you know they must have liked it a little bit. But they really felt that being able to have everything offered in their home location, an entirely safe space for many of them, discrete space for many of them, was an optimal location for them. So obviously, you know, it's expensive from a staffing perspective. This is a small addition to our existing outreach and fixed location services, but we feel moving forward it will be an extra layer of care for a particular population that even hadn't been reached by the range of outreach activities that we'd already offered. And clients reported that local delivery, flexibility, and the peer relationships that allowed us to access them at their doorstep was really key in terms of engagement. So thank you very much.
Great, thank you so much. We've got a minute left in the session, so if there's a burning question at the mic, we can take it. If not, thank you all for attending, and enjoy your lunch.